Hi there, Dr. Erica Wood, and we're going to talk about all the other senses that we need to talk about. I'll share my screen and we'll get started. Okay, so we're going to start out with talking about smell and taste, and they kind of go hand in hand together. So smell is also known as olfaction, and taste is known as gustation, and they work together so we can know if something is good to have or let's avoid it. Everyone has their different tastes and likes for smells, but overall, we all have chemoreceptors that are used by these taste and smell systems. In the nose, we have chemicals that are excited by the little receptors in our olfactory roof and olfactory sensory nerves, and they dissolve in nasal fluid. And then taste receptors respond to chemicals that are dissolved in the saliva. So remember in the nose we were talking about a few weeks ago, we have olfactory epithelium. I keep pointing my nose up here like it's going to do something, but olfactory is our organ of smell. It contains those sensory neurons that bring the reception of the smell straight up to our brain by the olfactory nerve. So right here are those little olfactory bulbs, and it's bringing sensory information right to the olfactory tract. We're not going to go into huge depth about this, but just understand that there are different types of olfactory epithelium. There's specialized dendrites and specialized different types of neurons that bring in special senses. In order to smell a substance, it needs to be something called volatile, which means it must be in a gaseous state, and the odorant must be able to dissolve in the olfactory epithelium fluid. So how do we activate our olfactory sensory neurons? So basically these dissolved odorants can bind to certain receptors that are in the cilia of the olfactory membranes. And depending what happens or different triggers, it can open channels that generate receptor potential. And at threshold, an action potential is conducted that sends our first relay station in the olfactory bulb going, something smells great or something smells yucky. So we're hearing a lot about this in COVID, that there's anosmia, which means that you cannot smell. Sometimes this is due to head injuries where you actually injure the olfactory nerves themselves. Sometimes there's a lot of inflammation. So we know by our research on COVID this week that, or next 2 weeks, that it is actually an inflammation of small vessels. That makes a lot of sense. And then certain neurological disorders like Parkinson's disease can have this. Sometimes we could also have something called olfactory hallucinations, which the temporal lobe, it's a type of epilepsy where basically a certain smell happens right before, or a certain smell is kind of almost thought it's smelled right beforehand and cause seizures. So that's really it for smell. For taste, it's a little bit different. So taste, you have lots of different taste buds. These are your organs for taste. So taste buds, hence the name. We have a whole bunch of different types of taste buds. We have fungiform taste buds, or papilla, which are these mushroom-shaped little structures that house most of the taste buds. They're scattered all across the tongue. The side walls of your tongue have called foliate papillae, and then you have the valate papillae, which are at the back of your tongue forming a V, and they're our largest taste buds. I have a couple in the soft palate inside the cheeks and pharynx and epiglottis, but not too much there. So you guys will learn a lot about this in dental anatomy. But here are those foliate taste buds. The fungiform are all abound. And then we have our, oh my gosh, sorry, it's been the validate taste buds back here. Sorry, it's been a day. All right, so then each taste bud has about 50 to 100 of these different types of epithelial cells. That there are 2 different types that are in there. We have something called gustatory epithelial cells, and they're specialized taste receptor cells. They have little microvilli that are little hairs, and these little hairs project into taste pores and are bathed in saliva. So what ends up happening is that some kind of chemical comes around, the sensory dendrites get the signal, and it sends a signal to your brain about these taste buds, about what you're tasting. And then we have basal epithelial cells, which are types of stem cells that can divide. That's why our tastes evolve over time. So here's a little cross section. Here's a little taste bud, and here's a little cross section of it. You can see all this neuro anatomy or neuro conductions coming up through here. We don't really need to know them that much in depth, but we do need to know there's different types of tastes. And we have 5 basic taste sensations. We have sweet, which is normally from sugar, certain types of alcohol. Some salts that are lead-based give a sweet taste. We have sour. The sour taste is produced by hydrogen ions that are in the solution. We have salty, that's normally from metal ions, normally sodium chloride, tastes saltiest, and that's the most safe for us to consume. We have bitter, which is known as alkaloids. So caffeine, aspirin, nicotine, these are all things that are produce a bitter taste, but we also have what's called bitters, which are vegetables that have a bitter taste because they have these high alkaloid contents. Then we have umami, which is mainly from amino acids, glutamate, and aspartate. Sometimes beef, cheese, and then MSG, if you care to have that in your diet. These give an umami type of flavor. There's a new possible evidence that there's a sixth taste, and that's to be able to taste fat, but why people look for fatty foods, but also fatty foods tend to light up our pleasure centers in our brain because we think we're satiated. So different things there. And there's homeostasis that's involved in taste likes and dislikes. It's really, if you had something harmful, then that's going to guide how you taste things and how you want to taste things. And if things that are sour or bitter tend to be something that we shouldn't be having in our body all that often. So typically things that are poisonous or spoiled have a sour appearance, and that's a way of protection for us as a homeostatic mechanism. So remember, just like with smell, but with taste, so it's a chemical that we're tasting, literally. It's dissolved in the saliva, it diffuses into taste pores, and there's gustatory hairs that that sense that and bring the information around. We have taste receptors that get activated. So when we need to taste something, these food chemicals cause a depolarization of a gustatory epithelial membrane, cause a little bit of a neurotransmitter release, and that kind of goes in and tells us what taste receptors went off. Our taste is governed by three big cranial nerves that you guys should all know and love. We have cranial nerve 7, facial nerve, glossopharyngeal nerve. So the facial nerve is the anterior 2/3 of the tongue. The glossopharyngeal nerve, which is 10, is the posterior 1/3 of the tongue and the pharynx. And then the vagus is the epiglottis and lower pharynx, which does have a little bit of taste buds there. And taste is really important. Taste helps trigger digestion. So ever heard of Pavlov's dog, where the dog knows that the bell's ringing and it knows it's going to get food, so increase saliva. We increase saliva, we help our body's ability to break down carbs. We increase, when we like the taste of food, our body tends to make more gastric juice so we can digest and get the nutrients out of it. And taste can actually have protection also. Certain tastes cause reflexive vomiting because that means it's not good for us, or possibly our body views it, and cause gagging, so you know not to have it. So why taste and smell are interlocked? Because taste is about 80% dependent on smell. So if you ever notice that you had a really bad cold and your nose is blocked but your food tastes bland, and that's because these chemicals all work on the same type of experiences. Mouth also has things that are thermoreceptors, mechanical receptors, and nociceptors, which means that temperature and the texture of food can help either enhance or detract from taste. So that's why some foods are better hot than cold. Spicy foods can cause pain receptors to go in your mouth. Some people love that sense of pleasure from it, and some people don't want to come near them through what it goes chili pepper. And things that can happen in taste disorders, that upper respiratory tracts, remember that smell is about 80% involved in taste, head injuries, chemicals or medications that destroy the taste buds, radiation treatment. And then a lot of times, especially like in children that work with autism, a lot of times a zinc deficiency can alter how someone tastes things. So zinc is a really important nutrient for taste. So what was that you say? We're going to talk about hearing and balance. So really important to know, that's a repeat, sorry. Really important to know the major parts of the ear. We got the outer ear up here, which is what everyone sees and pierces. It's only used for hearing. We have the middle ear, which is only used for hearing. And then we have the inner ear, which is the inside of our brains and really not inside of brains, inside our head, which is hearing and equilibrium. And there's receptors for hearing and balance that respond to different types of stimuli and can act independently. So what you might be spinning around, you could still hear, but you get really dizzy because your equilibrium is thrown off. So the outer ear, I'm going to show you right here. So we have the auricle, which is the whole entire thing, or pinna. It kind of acts as a megaphone to bring the sound more into the ear. We have the helix up here, which is the cartilaginous area. A lot of people like to get this pierced, and the lobes are what a lot of people like to get pierced as well. We have an area called the external acoustic medius, which is also auditory canal, which is a little ear tube that goes into the inside of your head. And its job is to transmit sound waves. So the ear is the megaphone funnel, bringing it down into the ear. Then the canal helps bring those sound waves to bounce a little bit more and brings it to the eardrum. Eardrum, the break off of the middle ear from the external ear is a tympanic membrane. So it's eardrum. It's what we see. It's what we hear about things, literally. It is a thin translucent membrane, and it responds by vibrations to the of sound. And its job is to, like a drum, literally like a drum. It feels the beats and transfers that sound energy to the bones of the middle ears, who will oscillate or move to make certain things happen to send information to our brain based on how those bones are vibrating. Okay, so here's a little view of the ear altogether. And remember that we have an auditory tube or the pharyngotympanic tube, which is why sometimes we have a sore throat, we have feeling in ears, and vice versa. So here's a cut down of the tympanic membrane. That's your eardrum. Beyond the tympanic membrane, we have these three ossicles that are responsible for vibrating, and those vibrations then cause a fluid to move, and we'll get into that in a moment. Okay. All right, talked about our station tubes. So here we have the three bones of the ear. They're the most smallest bones in the entire body. Okay, the first one that you're going to see if you're looking at the inside of your ear with an otoscope, you're going to see the malleus. Okay, the malleus looks like a hammer. Then you're going to have an incus, which looks like an anvil, and the stapes, which looks like a stirrup. Okay, these ears, what happens is that the malleus is secured to the eardrum. So the eardrum feels the vibrations. The hammer goes bump, bump, bump. Anvil goes bump, bump, bump. The stirrup goes bump, 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 and it fits into something called the oval window. And through this, what I really want you to understand is that the vibrations and the movement of the bones of the ear is what causes sound to be translated, okay? We also have a couple of skeletal muscles that I'm not going to go to huge depth on, but there are a couple of skeletal muscles that are responsible for helping with your bones moving, okay? Common thing that you're going to see, of course, as clinical dental hygienist, is you're going to see an otitis media, which is a fancy name for an ear infection. 9 times out of 10, ear infections are viral and actually will clear up on their own. What we're concerned about is when that viral or that fluid that gets caught up behind the eardrum causes to become bulged and becomes infected. And that's when we have what's called acute otitis media, which is when you get amoxicillin or cephalexin or whatever you need for that. Sorry. Okay. And then internal ear. So we went from their middle ear to our internal ear. Internal ear has what's called a labyrinth, which is also known as a maze. It's right behind that temporal bone and behind the eye socket. We have two different areas. We have the bony labyrinth, which is a bunch of little channels and cavities that go throughout the bone. And these areas are what's responsible for sound. So this bony labyrinth gets divided into a vestibule, semicircular canals, and cochlea. And what you need to know is that these areas are filled with something called perilymph. They're very similar to cerebrospinal fluid, and what happens in that perilymph transmits to sound. Then we have the membranous labyrinth, which is a bunch of membranous sacs and ducts that are filled with potassium-rich endolymph, and that's important when if you get into the physiology of hearing. So this is what it looks like. Here's that cochlea. So a lot of people who can't hear because there's damage to their cochlea will go cochlear implants because that helps transmit the sounds. Vestibule is a little egg-shaped cavity in the bony labyrinth, and it's continuous to cochlear duct, and it's continuous to semicircular canals. And what its job is it houses the equilibrium receptor. So if I'm turning my head this way or gravity is turning, it's actually sensing which direction my head is turning in, okay? Semicircular canals, they help orientate our space area of how we feel in space, so anterior, lateral, and posterior. And they help us figure out where our head is in space. So if we rotate this way and that way, it helps figure it out, okay? That's another cross section here. As I said, cochlea is really important. Cochlea houses the spiral organ of Corti, which is all the ends of the cochlear apex, all the little nerves that connect to that vestibular cochlear nerve that are responsible for sound. And the most important thing about organ of Corti is that they have these little hair cells, and they are little, there's inner hair and outer cell, and they're sandwiched between these two little membranes. And what ends up happening is that in the cochlea is where the nerve 8 runs to our brain. So cochlea, it's called spiral organ of Corti, and that connects to our brain. And when these basilar membranes, when those hairs either shift or change, so we're taking a look here, taking a look here, taking a look here. The centurial membranes changed. They cause those cells to bend. And depending on what we're doing and where we are, as far as that, the bending is telling us what type of sound is happening, okay? So sound gets projected as waves. So they look like wavelengths that come in like this. Basically, sound waves are created when an object moves. So that's the most important thing to know there. So a lot of times you hear people with a tuning fork, and normally if this was a lab, I'd have you guys do a tuning fork exercise. So tuning fork, we're taking a listen. We strike the tuning fork and we're seeing how fast or how soon or how long we can hear that sound. Because what it's doing is causing this wavelength to come through to our ear, our tympanic membrane, which causes the whole boom, 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 boom on the ossicles and moves forward. A couple of things that affect the sound is that the frequency, the number of waves that pass a given point, and the wavelength, which is the distance between two crests. Or so basically it's how we measure the frequency of sound. We measure it by wavelengths. And then a couple other things to add to sound besides frequency. So the human hearing range is about 20 to 20,000 hertz. Not that you guys have to memorize it, but pitch is important because the higher the frequency, the higher the pitch is, and the quality is the characteristics of the sound. So the tone, a lot of times people say I'm monotonous, which I don't mean to be. And some go high, low. That's the quality and the tone. Okay. And that's how we make music and how we sing. So pathway of the sound here, remember what we talked about here, is that we got sound waves that vibrate the tympanic membrane. The tympanic membranes cause the auditory ossicles or the bones to vibrate. Pressure is amplified inside that little tube. We get a pressure wave that actually occurs from all this vibration, and that pushes onto an area called the oval window that pushes fluid through these semicircular canals and the cochlea, okay? And the sounds with frequencies that are below the hearing range travel through the area and don't excite the hair cells, but the ones that are in the hearing range actually excite the hair cells, and then they go through the cochlear duct and they vibrate, and then two little membranes move together, and you got a sound produced. Okay, so some things about auditory processing is the perception of pitch. Impulses from hair cells in different positions determine of how we hear the pitch, so different sounds are heard in different areas. Detection of loudness is determined by the brain as an increase in the number of action potentials or frequencies. So the louder a sound is, the more like the hair cells are bending and getting deflected more. And then localization, where the sound's coming from, it really depends on the intensity and the timing of the sound waves by the time they reach both ears. So a lot of times when we're testing hearing, we have you plug up one ear and then we can tell which side is being affected. So that's all about sound. So in a nutshell, what you guys have to understand is that the sounds are being produced by what I'm saying out loud to you. The sound is then vibrating against the eardrum, tap, tap, tap. Ossicles are vibrating and moving around, tap, tap, tap. This causes pressure to build up and causes fluid to move through these semicircular canals and cochlea. Boom, boom, boom. This pressure and this movement of fluid causes hair cells to bend. Boom. Those send off excitatory impulses to the vestibulocochlear nerve. It goes back to the temporal lobe to think about what we're hearing and translate it. Equilibrium is the ability for the body to sense balance and where they are a sense in the world. Okay, so the head is really, when we move our head in certain ways, that's how our equilibrium is achieved. It's then called the vestibular apparatus, which is the semicircular canals and vestibule, and those are really responsible for making our equilibrium. We're not going to go into too many details here about how equilibrium is kind of regulated, but we have to know that is also the same idea as there's different type of hair cells. They're called kinocilia, and the kinocilia, when they're bent or when the fluid moves past them, they go through an action potential and then also send information back to the brain. So the brain knows that if the hairs are bent another way or the fluid moves another way, then the head is changing position so we can keep our balance and our equilibrium. So example right here is that if our head's right up, the gravity is pretty standard and there's a steady stream of action potentials. But then when we move our head forward, we're actually causing the hairs of the kinocilium to bend forward. These hair cells depolarize and action potential is being sent back to our brain to say we're now moving our head forward. Same thing for moving back, but the opposite direction. It goes hyperpolarized. So how does this come into play? So a lot of times we see nystagmus, which means we'll go back there. So motion sickness is normally because there's sensory inputs that are mismatched. Normally you find it on a boat or in a car because you're getting all these different visual inputs and it's not matching up or keeping up to what's happening in the equilibrium input in your ear and vestibule. So it kind of comes out as bleh all over the place, okay? There's two different types of disorders that you should know about there as far as deafness goes. So deafness is the loss of hearing. We have this thing where the actual blocking of the sound can occur to the internal ear. That's called conduction deafness. That's normally caused by earwax, perforated eardrums, otitis media, and a couple of other things that we're not going to get into. And then we have where the actual nerve is damaged. And the actual nerve is normally from loud sounds. Is that he listens to really loud music in her headphones normally causes gradual loss, hair cell loss, and that's what causes sensory neural deafness. So someone who has sensory neural deafness will probably need a cochlear implant like this boy. So basically it's acting like it's cochlea. It's taking the information that is being sensed from all the different vibrations that are being changed throughout the fluid, bending these hairs, and it's amplifying and bringing that information back to the brain so it can make use of it. That's it for our special senses. It's not too much in depth. You don't really need to know that much too in depth for the purposes of what I believe that you need to know, but this is the basics of it. I hope you enjoyed it. If you have any questions, please feel free to ask. Thank you. Bye-bye.